Hi, everybody. Welcome to another episode of the GenoCare podcast. I'm joined today by Kirsten Boggs, who is a senior genetic counsellor and a researcher. And I have had the pleasure of working with Kirsten on two big projects relating to reproductive genetic carrier screening. So, welcome. Thanks for joining us.
Thanks, Ellie. Lovely to be here.
So, we're going to talk about all things reproductive carrier screening today. And Kirsten and I first met when we were both working on Mackenzie's mission, which we'll talk about a little later. But over the years, we have spent a lot of time thinking and talking about this topic, which we're both very passionate about. But let's take a step back, and just for anyone who's listening who's newer to this topic, I'm interested to know, to start off with, how you usually explain what reproductive genetic carrier screening is and why it's becoming part of routine reproductive health care.
Yeah, so I guess I'd explain reproductive carrier screening as screening of either prospective parents, so screening in pre-pregnancy or in early pregnancy to see basically if people are carriers of a particular genetic condition that then may increase their chances of having a child affected with that particular condition. I guess it's a bit more complicated than that, but that's the simplistic version. And essentially, as you said, Ellie, we've been talking about this for years and working in this space for a while now, but it's obviously gained traction and made its way into routine reproductive health care because there's now carrier screening available as part of the Medicare item number for 3-gene screening. So that is screening that is offered pre-pregnancy or early pregnancy for people looking at the three most common genetic conditions, depending on what ethnic background you are from. But maybe we'll talk about that later. And so it screens for cystic fibrosis, spinal muscular atrophy, and Fragile X. And so because of that access now being available on Medicare or getting a Medicare rebate, obviously it's filtered down into primary care and GPs talking to prospective parents about this type of testing, which potentially wasn't happening before.
Yeah, and so we've seen this massive shift really from carrier screening only really being available to those who knew about it and those who could afford it, to it now being available to anyone who's planning a pregnancy or an early pregnancy. And I guess just to stack on what you're saying, Kirsten, we have two different types of carrier screening options. So we have 3-gene carrier screening, which Kirsten mentioned, and that's what's covered under Medicare. Then you can also be screened for a much larger number of genes, so anywhere up to just over 1,000 genes, depending on which provider you use. And that will screen for genes associated with severe childhood onset genetic conditions. So when we talk about carrier screening, it's actually super hard to talk about it succinctly because there's so much
So many options
go into. But today, I think what we're trying to do is focus on how it fits into practice. So rather than the nitty-gritty of how carrier screening works, which we'll cover in another episode or maybe more than one other episode, but just, how it fits into practice and how the landscape's changing. Kirsten, you've been working in this space over the time between before we had a Medicare item number and now that we do have a Medicare item number. So how is it typically fitting into practice now? What do you think is working well? And then what do you see the gaps or challenges are for patients and clinicians navigating it now?
Yeah, so look at how it's fitting in now is pre-Medicare item number. I guess, as you mentioned, that kind of awareness from the healthcare professionals was really lacking. So I'm not saying that it's perfect now, but I guess for non-genetic healthcare professionals, really, there wasn't a lot of information available for them to learn about carrier screening and the options available to their patients. But then also because there was no funding, I don't know that people were accessing it as much as they are now. So it's having that cost barrier removed has opened up possibilities, I guess, for access through primary care. So Medicare item, I guess, as part of the genetics services across the country, a lot of carrier screening was being ordered through genetic services rather than GPs and other non-genetic health professionals. I think that's really shifted the way that things are being offered. What do I think works well? I think, obviously, like I said, removing that cost barrier has changed things dramatically. And with Ali, you will know that we worked on mapping some of that accessibility across Australia, and particularly in metropolitan and regional areas. And there's a stark contrast between what was happening pre-Medicare item number in terms of access of 3-gene screen and now post that barrier being removed, is that access has just increased dramatically. And seeing that visually across a map is pretty dramatic, actually, the change. So I think it's removed some of that inequity of access that's so often talked about when we talk about population screening. That's probably what works well. I think there's many gaps, unfortunately, still. And that's not to say it's great to have this funding, and it's so great that it's part of routine pregnancy care or pre-pregnancy care, or becoming routine, I should say, because I think there's still education lacking amongst non-genetic health professionals. But I think the gaps are that, obviously, the 3 genes that have been selected, well, I said before, these are the 3 most common conditions, I guess, amongst the Caucasian population in Australia for people to be carriers of CF, SMA, or Fragile X. That's potentially not the case across multiple other ethnicities. Obviously, it gives you information about those 3 conditions, but certainly doesn't cover anything like expanded carrier screening, which, as we talked about, is accessing screening for, up to a sort of and over 1,000 different genetic conditions. Whilst some of those are incredibly rare, they're incredibly severe. And I guess, having worked clinically as a genetic counsellor at a children's hospital, like, I've witnessed parents going through the diagnosis of a child with a rare but very severe genetic condition. And I guess that's the goal of carrier screening, is to try and give people information to avoid that if they want to. So I guess that's the gap. There's no funding for expanded carrier screening at this point in time. So that's still, people pay privately, and with private access, you're obviously going to create inequities within the healthcare system of people accessing expanded carrier screening and those who can't afford to. So widening gaps in healthcare. I think the education piece is really tricky because, obviously, GPs and other sort of primary care physicians and other non-genetic health professionals have so much to think about in the context of a pregnancy. This is just one component that clearly we are very passionate about as genetic counsellors, but it makes up a larger proportion of the other discussions that need to be had with patients. But it's really important to get it right, because then if you're not giving the right information, I'm aware of people that have been told, oh, carrier screening doesn't apply to you because you don't have a family history of a particular condition, or there's nothing in your family history to suggest you should access carrier screening, which is obviously, as we know, normally the first instance of a child being diagnosed with a severe genetic condition. That's the first instance in that family. So there's usually not a family history. So I think, that educational gap of who should qualify for carrier screening, what it is, the differences and the nuances between that 3-gene screen versus expanded screening, like, that's quite complex. What to do with results when people come back as being high chance or being a carrier of a particular condition. And then I think with the 3-gene screen, I guess it's working well enough. Obviously, that's done at an individual level. So usually it's the female partner that's screened first. And then if she is found to be a carrier of SMA or CF, then we'll go on and screen the male partner. Now, obviously, that's quite a heavy resource burden for laboratories and also for the healthcare professionals involved. And so when you think about expanded carrier screening, doing it in that sort of individual screening way is probably not going to work well, because you're going to come back with people being carriers of conditions and potentially raising anxiety when you don't necessarily need to, depending on the carrier status of their partner. And there needs to be models based around that when we're thinking about expanded carrier screening, definitely.
There's so many things in that. I want to ask you a bit more about the education considerations. But before I do that, I just want to explore a little bit more one point that you mentioned, which is I'm curious to understand a bit more about why carrier screening is so important to you as a genetic counsellor based on the clinical work that you have done and that experience that you have. And I'm just interested, you touched on that briefly, and I'm interested to understand a bit more about that.
Yeah, so I just started as a genetic counsellor in the clinical genetics unit at one of the children's hospitals in Australia. And I guess was exposed to that kind of diagnostic odyssey of parents with a child that was affected with a particular genetic condition, but we weren't able to make a diagnosis. Like they hadn't been taken seriously for a long time by other medical professionals. It was from the time that they were first worried about their child to even coming to see genetics, for example, it was averaging about 5 to 10 years, let alone accessing genetic testing for them and making a diagnosis. That in itself is really tricky. And then I guess as I moved through my career, I got heavily involved in the Acute Care Genomics project. And so I was the lead genetic counsellor in New South Wales for that project and through a lot of families through that. So that was where we were offering rapid trio whole genome sequencing to critically unwell children in NICU and PICU. And yeah, that was life-changing for me, I guess, from a career perspective, but like personally as well, being exposed to families in that really incredibly traumatic environment. There was often NICU, so they were newborns who were severely unwell, and we were making diagnoses for them within a matter of days of really severe genetic conditions, often where there was no treatment. And very sadly, a lot of those children were palliated and redirection of care into palliation and eventually died. And so I was on that project for 4 years. And I guess just really, not that my perspective was different before that anyway, because I always believed in carrier screening and there should be something available so that people can know this information and kind of plan and prepare if they want to for an affected pregnancy or kind of make a different decision in a pregnancy based on that information. But I guess, yeah, just seeing these incredibly distraught parents and thinking we'd done all the testing, they were confused because they'd done NIPT, for example, and they sold the idea of that's the genetic test and that sort of guarantees you, for lack of a better word, a healthy baby. And so to know that there was testing out there that was available but not offered routinely because the healthcare professionals were not aware of it or didn't have the confidence to offer it, and that basically those parents could have avoided being in that situation had they have known. And obviously not dissimilar to Mackenzie Casella's story. It's the same story, essentially, that they could have known about this prior to Mackenzie being born, and that's why Mackenzie's mission existed. But to have to sit across from families and after delivering a really devastating diagnosis and for them to look at us and say, could we have known about this? And having to say, particularly now, yes, actually you could have, but unfortunately your GP didn't know enough to offer this to you, is a really horrible conversation to have in the midst of an already really tricky and horrible conversation. So that is why I'm so passionate about it. And I've seen how this is so life-changing for people, particularly once they know that they're carriers of a condition, they can actively avoid or take steps to avoid having another child with that condition, and just to be aware and not be caught off guard, even if they don't make the decision to go through IVF PGT or they don't make the decision to test in a pregnancy, to be forewarned that this is a possibility and, you know, that we'd support them along the way no matter what. Yeah, that's in a nutshell why I'm so passionate about it.
Yeah, and you know, that's absolutely what comes out in all the research publications too. And I even remember, because my PhD was on attitudes towards carrier screening for Fragile X syndrome, and I remember I had a theme called Forewarned is Forearmed, where people were consistently talking about being empowered by having the information and being able to make choices. And I guess you've just had that real depth of experience and working with people who haven't had that information and haven't been or have been disempowered by not being able to access that information and having those really challenging experiences. And so I guess that's a great segue for us into talking about Mackenzie's mission, which is one of the reasons we wanted to do this, record this podcast. So as I mentioned at the beginning, I met Kirsten through Mackenzie's mission, and we've worked together now on another project after Mackenzie's mission too, relating to carrier screening, which we'll talk about in a moment. But for those who are less familiar with Mackenzie's mission, very briefly, it was a large national research project which looked at how to deliver reproductive genetic carrier screening for a large number of genes. And importantly, it was really about how to do it at population scale. And it's named after Mackenzie Casella, the beautiful daughter of Rachel and Johnny Casella. And it came about after they lost their beautiful daughter to spinal muscular atrophy, and asked the question, why didn't we have the opportunity to know this earlier? And around that time, there was actually a lot of research that had already been done showing really strong support for carrier screening. There was some good national data that existed. And there are people who had been advocating for it for a long time. And by sharing their story, they were really able to get that message into government, and government then announced Mackenzie's mission, which was a really large research project looking at how we would do carrier screening at the population scale. And we could spend ages talking about what carrier screening is and why it's important. But I think one of the really interesting things about Mackenzie's mission, not just about the actual screening and the testing itself, or about whether people wanted to have it, was really about delivering testing in a different way. And so, Kirsten, I'm interested, given you lived and breathed Mackenzie's mission like I did for quite a number of years over that time. From your perspective, what do you think that model allowed us to do differently?
Yeah, look, so many things. Firstly, just going back to when I was talking about the 3-teen screen, and that's offered individually, one of the big decisions that we made early on was that we would offer couple-based screening. So we would test the female reproductive partner and male reproductive partner at the same time, just to avoid that entire scenario of, because all of us are carriers of at least 2 or 3 different genetic conditions, avoiding that huge burden of work for not only the laboratory scientists, but the genetic counsellors working as part of Mackenzie's mission as well, and having to interpret those results for people when most of the time they weren't actually going to impact any reproductive decisions being made by the couples. I feel like that was a little controversial at the beginning. I don't know that it's so controversial now that we've done the study and we showed that it worked really well. But I think people were, enmeshed with this traditional view of how to do carrier screening, and that part of it is about information for the family. And so when you find out that somebody is a carrier for a particular condition, even if their partner's not, and there's no risk to that couple, that traditional genetic counselling model is about letting the family know, and if there's siblings and other people in the family planning pregnancies. So I feel like, while that's completely valid, there's no way that works at a population level, because of the amount of work that is involved, and you would have to employ, hundreds of genetic counsellors to manage that workload, let alone the scientists. And we don't have that workforce. And I just don't know that those results are particularly meaningful. If we remove all barriers in access to carrier screening, particularly expanded carrier screening, then you would hope that anyone who is planning a pregnancy, even within the same family, are going to be accessing it. So it removes that need for dissemination of results through the family. So I thought that worked incredibly well, and it did save us a lot of resourcing to do that at population scale. I think another thing that we did, fortunately, because we did launch Mackenzie's mission in March 2020, and we all know what else happened in March 2020. So huge COVID impacts. Fortunately, the way that we were recruiting couples into Mackenzie's mission was through an online consent platform. And so this kind of allowed information. We didn't have to go out to particular hospitals and talk to people about the study. People could access information online. They went through education. They did a decision aid to help place them as to whether they were considering carrier screening or not, in line with kind of their values and belief systems, which I think was really important. And then to do their consent online as well. And then all of that, it sounds so simple. I know we spent so long designing it. All of that triggered the lab to then send out mouth swab kits to the couple's home address. So they didn't have to have a blood test. It was a mouth swab that they could do at home. And they sent it back to us in a reply paid envelope. So trying to, as much as we could, remove any barriers for people accessing the study. So I guess, the online consent platform was, I thought, incredibly useful. I know we spent a very long time designing all of that, the education content and how it would all run. But yeah, I thought it worked beautifully. And like I said, just really enabled people to access it no matter where they were, as long as they had internet access, of course, which I guess we were quite worried about that at one point, about people living remotely, whether they'd be able to access the portal, given that we weren't sure that people had internet access. And I think we printed out the information and everything in this huge document that we could send people a paper copy of. And as far as I know, we didn't actually end up using that at all, because most people were actually able to access, even if they were living remotely, they would present to their GP, who at least was practicing somewhere where there was internet access and people using mobile phone internet and all sorts of things. So actually not as big a hurdle as we might have thought originally. So I just made everything much more accessible. There was a way to contact a genetic counsellor if you needed to. So the preference was that people would do that online themselves, but if they had any follow-up questions or anything, they could email or call the Mackenzie's Mission hotline and speak to a genetic counsellor and ask their questions. And that was really helpful, I think, because some people did have specific family history questions and things that actually did change the way that information might be delivered, or the advice that we would give. Actually, maybe you're better off definitely have the testing, but to go and see a clinical genetic service just to get whatever's going on in their family sorted out as well. So I thought that worked really well. I think probably maybe we understaffed that to start with, just because of the admin burden and so on. But I think towards the end that we got that really in the amount of GC time that was spent in that pre-test counselling space, and obviously having most of the education and everything delivered online, that obviously freed us all up to be available for post-test counselling for people who came back as increased chance. And that's obviously where I think we can get the most impact from a genetic counsellor in those sessions. So we were saving those resources for the people who needed support to understand their increased chance result and to guide them through that journey. So yeah, I thought that was an incredible thing to be part of, actually. Yeah.
Yeah, it really was. It was an amazing project, and I think we all learned so much. And I feel for me, and I'm sure it's the same for you, Mackenzie's Mission came at a kind of critical, pivotal time in my life anyway, because I had young kids. And so I was trying to juggle raising little people in the pandemic and then play an important role in delivering this national research project. So it was like, it was quite the journey.
Absolutely.
But we were lucky to have an amazing team, and the genetic counselling team was a phenomenal group of professionals to work with.
Yeah.
So just following on from Mackenzie's Mission, that then leads into a project that you and I worked on together for Australian Genomics, which was really taking the learnings from Mackenzie's Mission, filling in some additional gaps, and producing a report to government about the need for a national carrier screening program. And I just wondered if you wanted to comment on that.
Yeah, and so I guess Mackenzie's was a really successful project, and I think we did a lot of things really well, but there were some gaps, particularly around engagement with Aboriginal and Torres Strait Islander people and communities, and then also with our sort of culturally and linguistically diverse communities as well. So I think what we did in Mackenzie's is we developed everything, and then we came back to, then we're going to go out to communities and we're going to talk to them about what they need and make changes from there. But in such a large scale project, the timing of that, I think we ran out of time to do that properly. And so I guess one of the very first recommendations that we've made as part of that document is that those communities need to be brought in and consulted with as soon as there is any announcement or funding available for a national carrier screening program. I think where we did try is we did have the translated versions of the portal. In Mackenzie's, we had it translated into Arabic and Chinese, or simplified Chinese rather. And so again, I think that was fantastic that we were able to do that. And I know that there's a lot of research projects that would be very jealous of us being able to spend funds on translating materials because there's often a budget for that. However, I guess a learning point from that was that translation into another language doesn't necessarily mean engagement with that community and buy-in from that community. And I think a lot of effort went into the translation of materials, but again, that kind of consultancy piece was missing. And so that's one of the other recommendations, is that when we're thinking about priority populations, that really we have to engage ground level with those communities in order to develop something that can be used by everybody. I guess in terms of infrastructure, we have basically recommended that same online consenting portal with a few adjustments be used. And obviously it's been a while now since Mackenzie's mission finished, so there'd be advancements in technology that could be used, particularly incorporating AI and things like that as well. So, of course, but that model of online consenting and couple-based screening, we've gone with the recommendations for that as well. Sorry, Ali, was there anything else?
I think that's a good summary. I might just take that opportunity to dive a bit more into the use of a digital platform for online education and consent, with the fallback of access to genetic counselling if people need it. What was your perspective on what we learned through Mackenzie's mission about how people engage with that sort of approach?
Yeah, look, I think overall it worked really well. I don't know that we had, I guess I did say that we understaffed it to begin with, but I do think maybe I was expecting more calls for pre-test counselling, whereas it was probably more like a lot of it was admin related work that eventually we ended up hiring admin assistants and admin support to look after those inquiries so that the genetic counsellor time could be more freed up to do actual genetic counselling rather than admin support. And so I guess I thought that there'd be a bit more pre-test counselling to have to get involved with, but I think actually it worked really seamlessly. I don't know that a lot of people were accessing it, and probably the amount of people that were calling us was a good thing, and it was necessary for us to speak to them to get some clarification. I think as part of the digital platform, we asked some family history questions as part of Mackenzie's mission, just to flag, I guess, for us, if we were looking at particular variants down the track, was there a family history of that condition that might help us in the interpretation of the variants that we found? Or was there something that kind of needed a bit more exploration with that couple? And I think it worked pretty well, but I think we ended up having to get involved as genetic counsellors probably more than we would have liked, because there was a fair bit of follow-up. Because I think people were a bit confused, or maybe there was a way of asking those questions differently, which obviously we've learnt from that. And again, we're thinking about the tools that are now available a few years on, including AI tools to help us. Yeah, I think the point of it is to help free up the genetic counsellor time so that we can spend more time not on admin tasks and not following up family history and all of those things, actually doing genetic counselling and helping people make decisions and helping people understand their information in the context of their own values and beliefs and their family history and where they come from and what they're bringing to the table. So I think that is the unique skill of a genetic counsellor that needs to be amplified, and then to take away all of that admin burden. That's the job of the digital platform, so that we can do what we were trained to do.
Yeah, and I think that's been a big learning for me too. It's like the digital technology empowers us as genetic counsellors to do the meaningful work that we do that only a human can do. And reduce all of that administration and also repetitive work. So having a lovely education video that explains what genetics and inheritance is and how that works, so that someone can watch it and understand that, and you're not having a genetic counsellor having to repeat that 15 or 20 times a day. And now I'm looking at it also at the tail end when you're supporting people through getting results. There's some content there that's repetitive. We talk about prenatal diagnostic procedures, CVS and amniocentesis, and we deliver the same information all the
Yeah.
time. Well,
It's like a spiel, isn't it? Yeah.
why can't you have an education video that you send your patients before the consult so that they come
Exactly.
into it knowing that information, and then you've got more time to sit with them and how are you feeling about this?
Yeah.
What was it like watching that video? What resonated for you? What are you worried about? And actually unpacking the emotional component,
Well,
checking
because
their
often,
understanding.
yeah, often I guess the most meaningful conversation you have is the one after you deliver the result, right? You deliver the
Yeah.
result and you give all the education. They're in a state of shock because they're not expecting the result to come back. So they're not really asking questions. They haven't been able to think of any questions because they've been hit with this news. So you do go into that information delivery of these are all of the options. And as you said, prenatal diagnosis, so on. And it's the follow-up conversation, whether that's over the phone or you schedule another appointment in a couple of days' time or a couple of weeks. I just feel like that gives people time to process the news, to think of questions not just about procedures, but about how does this fit in with their kind of values and what they would do in a pregnancy, what they would do in terms of accessing IVF and PGT. I don't know. I find those follow-up conversations are much more meaningful. And certainly in Mackenzie's, that was the case because normally we were cold calling people to deliver results. And I think that's important that is result delivery has a human connection to it because that's very important. People remember the language that was used and the delivery of that result. Then, like you say, videos explaining different things that people can watch and get that information in the meantime. And then, that we can have to sit down and have a proper conversation and make meaning for them.
Yeah, it feels like a better combination, doesn't it? And then people can also go back to those videos because often, and we've talked about this in previous podcast episodes, the emotional impact of results often shuts off the front part of your brain, which is the logical thinking, reasoning part of your brain. And it's a very emotionally driven time. And so often people actually, as genetic counsellor, I'm sure this has happened to you heaps of times as well, like what you think you've conveyed and what the person actually takes home can often be two totally different things because of the emotional state that they're in. So the other beautiful thing about digital resources is that people can use them at other points in time
when convenient to them.
They've processed the emotions, they're feeling a bit more regulated, and then they can go back and revisit the information and just get a better understanding. And that's so important for informed decision making further on.
Yeah.
I'm also conscious that you've been part of a number of other really interesting research projects. You mentioned the Acute Care Genomics project, but also genomic newborn screening. And I know digital platforms and digital tools are coming into play there. I just wondered if you wanted to, I guess, when you step back and you look at those other projects that you've been part of, just thinking about the key ingredients for responsibly offering genetic screening at scale, what population scale, what are the kind of commonalities across those projects?
It's interesting, I think, taking a step back because you can say, oh, make sure that you've got information and you've got videos and so on, but I'm taking a step further back and the word that comes to mind is trust. And I think for any kind of population screening program to succeed, the general public kind of needs to have trust in the platform that you're using, trust that the information that you're delivering to them is accurate and tailored information to their situation. But I think also that there's a bit of, I know there's a lot of media about data leakage or hacking and people's data getting used in ways that they weren't necessarily on board with. And so I think part of that, if you're building like a large scale screening program where you're going to use an online digital consenting option or digital platform to keep track of everything, you have to think about your data security and privacy because that's a huge thing. If people don't have trust in the system that you're using, then they won't use it. And so you will have invested money and time and effort into something that people won't use. So I think you need to have trust that their data is going to be secure and used in the way that you have said it's going to be used. I think there needs to be clarity around this is the information that's current at the time of us delivering it to you, but that information can change. So I think you need to be upfront about the limitations of the testing, as well as what we know now is not always what we're going to know in 5 or 10 years. I think there needs to be ways for people to access the information differently. So I'm a very visual person, so I'd probably would prefer to watch a video with some animations and have things explained to me, but other people like reading walls of text. So you should probably cater to those different learning styles and making it that there's people that I think we have to also, maybe that trust thing goes both ways. And I think we also have to trust in our general public or the people that are using the platform that they are making a decision based on the knowledge that they have, that we have provided. And we have to trust that information level for them is enough. What I'm trying to say is some people will go really in-depth, granular, reading everything, wanting to know everything. Some people just will skim over things and say, yeah, that's enough information for me to make that decision. I don't care about that. I'm just going to skip past it. And I think once you start getting too prescriptive with your content about they must read all of this and check this box and say that they've done all of this, like you're just getting to a point where I guess that's a bit paternalistic, I think. And we have to be comfortable with the fact that some people will make decisions and require very little information about it. And that is okay, because if things fall apart and they do come back as, I guess in the context of carrier screening, if they come back as increased chance, we know that there's a genetic counsellor at the other end of all of that can help them get through that information and get through that result and give them options. So I think if your platform is built on providing enough education for the people who want it, but that also there's a way for people to get what they need from it. But then you've got this kind of backup support system of your genetic counsellors at the sort of the other end of it. I think that is probably how you gain trust, but also a trust in your patient that they're making the right choice for them.
That makes perfect sense to me. And I guess just to wrap up with one final question, I guess we're at this really interesting point where we're moving from genomics being something quite niche to genomics becoming part of mainstream healthcare. And I think it's a really exciting time, but it also means that we need to shift and change our approaches and our systems to adapt to that. As a genetic counsellor, because so much of this conversation has been based on your experience as a genetic counsellor, how do you fast forward 5-10 years? What does this all look like? And what does it look like for genetic counsellors and the type of care that we are passionate about making sure people get?
Yeah, it's interesting because I think if you had have asked me that question maybe pre-Mackenzie's 5-10 years ago, I'm pretty sure I even did research on pre-test counselling and how important that was. And it should always, the gold standard is that you do pre-test counselling in person and you talk about all the types of results that we might get back. And then there's the post-test counselling as well. And I just think my view is entirely shifted in that pre-test counselling is excellent if you can access it. But I guess the post-test counselling is where we can make the most impact. And there's just not enough genetic counsellors in this country worldwide to be able to see the volume of people that actually need to be educated and consented when we're talking about genomics, let alone population scale. It's not possible. I do think that now is the time to be exploring different models of care around genetic counselling, traditional genetic counselling. There's still definitely a place for that, working in tertiary hospital centres. I guess within a clinical genetics unit, that's still super important. But I think increasingly as this kind of filters out into the community, we need to be out in the community as well. I just don't know how. It's not like there's enough of us to go and sit in every GP practice in the country, right? So it needs to become some kind of digital option where there's, I don't know, my vision would be like a national genetic counselling centre or something, and that it's funded nationally. We sit there and you can work anywhere, but I guess that people can access genetic counselling that way rather than having to go on a wait list to see a clinical genetics service, which the wait list might be 2 to 5 years, depending on where you live. So I think there needs to be a way of increasing access to genetic counselling out in the community. And that's probably the next step now that we need to work on now. So that when, I say when, I know it's already happening, but it's just going to get increasingly more problematic the more people are accessing genomics, pharmacogenomics, population screening, all of that kind of needs to be really a huge investment into how are all these people going to access genetic counselling, which remains very important because people are making life-changing decisions based on that information, whether it's in carrier screening or in other types of screening like cancer screening, for example. So that's probably where I would see it going. But I guess, yeah, we need government and other people to listen and to fund that.
Yeah, absolutely. And I know in the genetic counselling community, there's been a lot of work that's been done previously on getting a Medicare item number for genetic counselling, which unfortunately until now hasn't been successful. And I know that lots of people are trying to advocate for that, and it's really important. And I think we should continue to try and do that. But I absolutely agree with you that we need to explore multiple avenues for funding and looking at how we make genetic counselling more accessible out there in the community as well. Yeah, so much to talk about in that space too. But yeah, I think we've covered the really interesting journey we've been on with carrier screening as we've been active players in its evolution from niche to mainstream. And yeah, it's been a really interesting journey and will continue to be. So thank you so much for joining us today. I really appreciate your wisdom and insights that you're able to share. And it will be really interesting to see how this evolves and whether your vision for genetic counselling in the community could fruition one day.
Thanks, Ellie. Thanks so much.